So this is my first case, and it's all in your handout. So this gentleman rocks in your clinic on a Friday, late in the afternoon. 45-year-old Tongan male. His BMI is 37. He doesn't see you that often. And his blood pressure is 180/120. Your diligent nurse gave you a dipstick urine analysis, and he has a proteinuria. And his creatinine is 150. And he has nearly 1.8 milligrams per liter of microalbumin in the urine check. And we would like to know what to do next. Now, you can clearly see from the red dots that I put there a few sort of red flags on this man. It's easy to see that he's high risk for chronic kidney disease, being of a Tongan extract, and his metabolic profile is clear. His BMI is high. Worse than that, he's hypertensive, but he does have CKD or kidney dysfunction and a significant microalbuminuria. Let's see how we'll deal with this. So just looking at what we have here, first and foremost, we need to quantify the albuminuria. Now, not all proteinuria is albuminuria. I'll show you in the next slide just a little algorithm to look at this in more detail. So one should remember that not all proteinuria is albuminuria. First and foremost, we need to quantify his albuminuria to make some sense out of it. And we've got to remember that albuminuria is an important cardiovascular risk factor. Outside chronic kidney disease, roughly 10 to 15% of hypertensive patients have albuminuria, and it's a serious, dangerous intersection with cardiac disease. I'll show you in the next slides what I mean. So to quantify albuminuria, you need a 24-hour urine collect for protein, cumbersome, difficult, or you can do an albumin-creatinine ratio, where you basically divide the amount of albumin by the amount of creatinine in that volume of urine, which will give you an idea. And it correlates well with the 24-hour albumin collection. You also need to establish that this proteinuria is persistent, not after a hard working day in a labor. This is a relatively busy slide, but you can see that you need to sort of differentiate between different types of proteinuria on that slide. I'll leave you to read at this later, but just to prove the concept that we need to think about other things. Now, albuminuria can be present in few conditions: simple fever, infection, exercise, more serious heart failure, some non-inflammatory conditions, and it can be associated with hypertension. But the one we are interested in is the CKD and the hypertension. So the albumin-creatinine ratio, once again, you need to have an early pick in the next morning for this patient. And remember that men with higher muscle mass tend to have more creatinine in the urine, so their albumin-creatinine ratio is going to be less. So this man can have a deceivingly low albumin-creatinine ratio for what he should have. So just remember that. This is just a kind of a definition of the various numbers that we use here. And so why are we worried about albuminuria, and why is it so important? Now, outside CKD, albuminuria is a very important risk factor for progression of cardiovascular disease. Multiple trials showed a dose-dependent increase in cardiovascular risk, ranging from 2 to up 8 times higher than age-matched, kidney-matched patients with hypertension who have the lower to the highest level of albuminuria. This man has significant elevated albumin levels, and he has a high risk, and that should be factored in his management. High normal albuminuria is also a risk factor. This is some data from the HOPE trial, and you can see that the odds ratio for cardiac disease is ranging between 1.8 to 3, and it engulfs the whole spectrum of cardiovascular disease, from stroke to myocardial infarction to heart failure. The microalbuminuria is associated with a number of traditional and non-traditional risk factors. So it is quite central, or maybe the end product of multiple risk factors operating simultaneously in the same patient. And possible mechanisms, few, maybe endothelial dysfunction, maybe increased BMI, inflammation. The other facet to albuminuria is that it's a very strong predictor for renal impairment. So the nephrologists are very keen on checking it, and they have, as I'll show you in a couple of slides, a very good guideline is how frequent you should get your kidney function based on the albumin-creatinine ratio. So it's a central risk factor to be tackled. It's a central risk factor and theme in management and prediction of kidney disease and progression to end-stage renal failure. In this man, the GFR is 45, which puts him at CKD stage 3A, and his albumin-creatinine ratio is 25, or actually above 25 in this case, given that his BMI is 37. Now, this is just a sort of a relatively busy slide. All I wanted to show you is if you look at the box of all-cause mortality and you look at the lines, the red line is this man's albumin-creatinine ratio. Now, this is in the American scale of 300 milligram per gram, which is over 30 in our scale, which is roughly what this patient had. You see the red line, and you match it to the GFR, and it's hard at the end of a Saturday full of talks, but you can see there that the risk is about 5 times higher than somebody who has a normal albumin-creatinine ratio with a creatinine of 100. So it is a quite a high risk, and it's a serious problem. And all the graphs work more or less the same. Now, this is just to put the same slide in a slightly different way, where you can actually predict how much the risk is higher than a baseline, which is in the green, compared to the red. Once again, all-cause mortality, about 6 times higher in the red box. So we go back to our patient. You do the standard work of looking for secondary cause of hypertension. You try to look at diabetes, obviously, a cause of CKD, glomerulonephritis, autoimmune hepatitis B, hepatitis C. The urine is bland, it doesn't have any sediment. So glomerulonephritis is unlikely in this man. Well, lifestyle changes probably should drop to the end. They're probably the hardest for this patient. Treatment of hypertension, I think this is in this man, you have to start him on an ACE inhibitor with or without a dihydropyridine. Now, in the Cardiac Society meeting, there was a presentation from a late-breaking clinical trial, which was done in ACC. It's quite an interesting trial, where they looked at, it's a big trial done in Sri Lanka. They compared 2 groups. It's a hypertension trial. One group is on conventional antihypertensive therapy, and the other group is of half doses of 3 agents. So they gave a small dose, a half dose of telmisartan, which is an ARB, half a dose of felodipine, and half a dose of chlorthalidone versus conventional treatment. And the results is very, very interesting. In 6 months, about 70% of people on 3 agents achieved good blood pressure control at target, while only 40 or 30% of patients on conventional therapy achieved the target. And the key is a very interesting fact. The key is that most of antihypertensive agents achieve most of their effect with half dose. When you double the dose for a cilazaprol or felodipine or any agent to the maximum recommended by the manufacturer, you will gain very little, about 15-20%. Most of the gain happen in the half dose. So think about this when you see somebody like this who is busy, he has a job, he doesn't see you that often. You want to treat his hypertension well. You want to treat it probably with a single agent. Use multiple agents firsthand. Don't hesitate. Keep an eye on his kidney function. Look at secondary causes if you find them. In his case, I'll bet you lipid-lowering therapy would be indicated, given his high risk of maybe 15%. Aspirin would be a reasonable thing to start. And you monitor renal disease according to the renal guidelines. And the medications that reduce proteinuria, top of the line are ACE inhibitors and ARBs, found to reduce proteinuria or albuminuria. Non-hydropyridine calcium channel blockers certainly do the job. Thiazide diuretics do the job as well, but they do have metabolic adverse effects in the medium and long term. And I wonder about combination of half doses, and certainly we'll try with those patients. Targets of blood pressure, 120 to 130, over 80. I would definitely endorse this recommendation for these sorts of patients. Now, this graph is provided by the Nephrology Society of Australia and New Zealand. And on the left-hand side, you can see the gradation of CKD, and that is in relation to the proteinuria, the albuminuria, sorry, and the numbers are just how frequent you should check the kidney function. So this is just for the follow-up on the progression of CKD, which is this man's other more important or potentially very important problem. And this is from the New Zealand recommendations for early detection of CKD. You can see that this patient falls right there. So that's my first case. Any questions on this case? Shall we progress to the second one? Right, okay. So we get asked to see people like this for risk assessment. And cardiologists are very wary of renal patients. And I'll tell you why once we finish with this slide. But let's read the case. This is a 55-year-old Maori woman who is hypertensive, had end-stage, severe CKD, stage 4, with a creatinine of 250, and she had an inherited disease, adult polycystic kidney disease. She is 55, and she has positive family history for premature coronary artery disease. She's on amlodipine and atenolol for treatment of hypertension. She got this HbA1c of 38. She's not diabetic, obviously, and her LDL is 37. Her HDL is 1.5, and she wanted to talk about her cardiovascular risk. What are we going to do with her? So I'd like to sort of challenge this dogma, if you like, for risk equivalency. If you read the guidelines, and all guidelines are not dissimilar, they talk about the equivalency of chronic kidney disease to diabetes and to history of myocardial infarction. And if you look at that, it makes sense. There's some data to support it. This cardiovascular health study, which is a large registry data, give you the simple answer. They are actually equivalent, but are they equivalent? In the past maybe 10 years, certainly in the past 5 years, it's becoming increasingly apparent that this is not quite true. History of myocardial infarction in multiple registries in the world actually doesn't support the notion that the CKD is equivalent to myocardial infarction in terms of its risk for cardiovascular prediction. This is data from the Alberta Kidney Disease Network cohort, and it certainly showed that it's about a third or maybe 50% the risk. It's not nothing, but it's not 7.7%. And another trial there showed the same. I think it's clear that the rate of progression of kidney disease, the presence of proteinuria, other risk factors are the modulators, but certainly CKD is not equivalent, which is really important because it makes you more resilient in the face of this problem. Maybe give hope as well. You can change this disease or change the outcome from it from the cardiac point of view. In New Zealand, half of the adults with CKD have another CHD risk equivalent. So about half of your patients are people who actually should be seen as a care should be based on a 10-year risk, standard risk. And that is very reasonable, and that will help in in directing your lipid-lowering therapy and treating hypertension and everything else. I'm not saying don't give it. All I'm saying is that they are not equivalent. Just think about that when you see these people. So back to our patient. She is CKD stage 4. Obviously, you do her examination, you look at her other risk factors, BMI, whether she is adherent to therapy, does she work, very likely postmenopausal. And with that family history that she has, whether her parents, her brother and father have the disease, were smokers or not. You get the basic tests, your examination should focus on the clinical issues. I think in a patient like this, you would like to have an echocardiogram, I would say. She is at that level where you want to know whether she has hypertensive heart disease, she has any occult ischemia. Obviously, a renal ultrasound would be very useful. One would like to look for cerebral aneurysms given her CKD. You may or may not be able to get an MRA given her CKD, probably not. And what else to do? Well, you've got to dot all your I's and cross your T's, and her blood pressure control should be adequate, aiming for the lower targets of 130. I wonder if her beta blockers should be changed to a small dose of an ACE inhibitor. Some people might not agree. It takes a little bit of pain to monitor her kidney function. You don't want to deteriorate the situation. If she is on a suboptimal dose of a calcium channel blocker, you can double it. Certainly, beta blockers has been disputed as risk modifying in the long term in recent literature. So just think about that. In terms of coronary disease prevention, well, there is accumulating data that some of these patients who have very low calcium score potentially can be spared, or they have modified doses of statins if you have to. So I certainly see a definite role for a calcium score for this sort of patient. Certainly it would be cost effective in my view. And you'll be surprised, we do have patients with chronic kidney disease that we have done CTCAs on, and some do deliver unexpected surprises. Very clean coronaries with very little calcium. Threshold for treatment of cholesterol based on the guidelines is 4, and the LDL is over 2 is certainly a tight number, and these are their current recommendations. Obviously, a live donor transplant would be ideal. And just the final note is tolvaptan was found in a recent clinical trial to reduce the progression of CKD in patients with polycystic kidney disease by 50%. And that was a recent publication from the New England Journal of Medicine. These are some of the New Zealand guidelines for targets for people with CKD. Most of them are around blood pressure and lipids and glucose levels. And I'll leave you with these thoughts for the rest of the weekend. Thank you.
Now, Nezar, we have here a question. What is the association of high uric acid with heart disease? And should we actively get it down? Now, certainly we know about renal dysfunction and things with uric acid being high, but what about cardiac disease? It is something that we find is another not often mentioned risk factor. How important do you think it is?
Well, I think hyperuricemia is part of the metabolic syndrome. I mean, this is just part of the whole cycle of it. There is some recent evidence that there's potentially mechanistic effect, but whether they can be targeted in the future, that's a little bit hard to justify at this point of time. I deal with hyperuricemia as just part of a metabolic process, and are targeted only if there is gout. But certainly it's part of your deranged HbA1c, hypertriglyceridemia, and increased BMI, and hypertension, and the rest of it. But as targeting it specifically is probably a little bit too premature in my view.
Thank you for that. Any other questions at all from the audience? Well, I think it's time to conclude what has been rather a long day, but an informative one. Thank you.